So basically, what do you mean by weaning? Weaning is defined as a progressive decline in the amount of ventilatory support that a patient receives from a ventilator. It has 4 steps: progressive reduction in ventilatory support, so that slowly you get the patient supported by lesser and lesser amount of ventilator. What we tell the relatives, basically, less ventilator working, more patient working. That is how the things are. Testing whether the patient is fit enough to be taken off the ventilator. Then you need to test. There are some objective tests where you can actually assess whether first we'll have to check, of course, whether the patient clinically is fit for weaning or not. And then you have got some objective tests to say whether the patient is fit enough to be taken off the ventilator, and actually taking the patient off the ventilator and extubation. So our objective or our topic today is up to this level C. Extubation we won't discuss here, but then the other things we'll discuss. So when the patient is ready to wean, how do you know that the patient has been ventilated for whatever the reason? Sometimes the reasons are simple, like a patient who is undergoing a complicated operation, or patient had just a bad decompensated heart failure and the patient has settled, or it can be a difficult one, a bad pneumonia, bad ARDS, bad COPD, which have been ventilated. So after we have ventilated and the patient is somehow settled, basically the weaning should start early. As long as the patient is stable on ventilation, and we should think about weaning the patient, we need to, because no ventilation is good unless we have weaned the patient ultimately out of the ventilator. So we need to look at the underlying reasons for mechanical ventilation has been stabilized and the patient is improving. So suppose a patient has got, as I told you, decompensated heart failure, that has to be controlled, and then only we can think about weaning. Or the patient had a sepsis and we have controlled that, then we can think about weaning. The patient is hemodynamically stable or on minimal or no pressures. So a patient who is requiring a huge amount of vasopressors or inotropes may not be fit for weaning. I'll discuss why, because that is so. Oxygenation is adequate. That is, we have a sort of rule of the thumb that PO2, if PO2 is greater than 200, PEEP not more than 7.5. This is arbitrary cutoff. You can also, some people take not more than 5 or not more than 6. And FiO2 less than 0.5 or 50%. So unless the patient meets this criteria, there's no use talking about weaning. So a patient who is requiring very high oxygen or very high PEEP definitely is not a candidate for weaning. I mean, not to start even the process of weaning. The patient is able to initiate spontaneous inspiratory effort. That is also very important. The patient's neurologically or sense-wise should be so alert to have some spontaneous, adequate spontaneous respiratory effort. A patient who is deeply sedated or already the muscle paralysis is still working is not fit for weaning. There is some assessment programs, basically. These are, again, not always not, these are not, what do you say, I mean, these are not commandments that you need to meet all the criteria, but these are helpful. So it has got a general assessment and it has got also a respiratory assessment. So the one is hemodynamically stable, pulse rate, cardiac output, etc. if you're measuring it. Number 2 is that free from factors that increase or decrease metabolic rate. The patient should not have ongoing seizures, very high temperature, uncontrolled sepsis, bacteremia, hypothyroidism, hyperthyroidism, etc. So all these things, sort of things, should be excluded. Next, the hematocrit is more than 25. Again, this has been debated. We know that basically any hemoglobin more than 7 is good enough for weaning. It does not change the outcome unless the patient is having acute cardiac problem, coronary syndrome, or like that. Next, the patient is systematically hydrated. So a patient who is very dehydrated or overhydrated, that is not, they are not fit for weaning. They have to be well nourished. They have given a criteria of albumin of 2.5. Albumin may not be a good indicator, but a very low albumin might be a deterrent towards weaning. Next, electrolytes within normal limits. Particularly, you should be careful about potassium and then some ions which are not looked into. We don't look into them routinely, but a patient who has got a difficult weaning, you need to look into this. That is calcium, magnesium, and phosphate. Phosphate is not usually done, but then if your patient has got a difficult weaning, then the patient should be looked for hypophosphatemia. Pain control. A patient who is having a lot of pain may not be good because they are anxious, they are restless, and they will be good candidates for weaning. Adequate sleep and rest and anxiety relief. And these are subjective